Hi everyone, my name is Dani Chattenton and I'm a PhD student at the Institute of Cancer Research in Imperial College London. I'm going to talk to you today about drug delivery to a diffuse midline glioma model using short pulse-focused ultrasound and microbubble exposure. Diffuse midline glioma, or DMG, represents 10 to 15% of all brain tumours in children, with a 9-month median survival. Poor treatment outcomes are partly due to the critical location of the pons, which controls several basic functions, including breathing and swallowing. Therefore, we have to be really careful to kill tumour cells without significant damage to the normal tissue. This means that surgical resection and therapeutic radiotherapy are not viable treatment options. Moreover, DMG has a largely intact blood-brain barrier or blood-tumour barrier, resulting in minimal delivery of therapeutic agents to the tumour cells. So overall, there's a strong motivation for improved drug delivery to treat DMG. One method to improve drug delivery is the use of focused ultrasound in combination with microbubbles, which can increase the permeability of the blood-brain barrier. And the way this works is that microbubbles and drug are located intravenously, so in the bloodstream. We then target the ultrasound to a specific region of the brain where we want to increase the permeability. The ultrasound causes the microbubbles to oscillate volumetrically and results in an increase in permeability of the blood-brain barrier. Therefore, drugs can enter the brain. The use of focused ultrasound and microbubbles has been tested in clinical trials, and whilst effective, there have been some safety concerns clinically and preclinically, and the blood-brain barrier remains open for up to 48 hours. An alternative ultrasound protocol has been developed at Imperial, which could be better for DMG. And what this does, it splits up the long therapeutic pulses into shorter pulses that are emitted in a rapid sequence, emitting just 1.9% of the acoustic energy of long pulses. The benefits of short pulses have been shown in the hippocampus, including a more uniform drug distribution, which you can see in the image on the screen. This is important for DMG, as a uniform distribution of the drug in the tumour core and periphery is required for maximum chance of successful treatment. Also saw no detectable tissue damage. Again, this is important for DMG as we need to be careful of long-term neurological deficits to a child's developing brain. So here we investigate whether we can get these benefits in the pons region, which is deeper in the brain and near the skull base, which could reflect sound and cause damage. This is an overview of the experimental protocol and our setup. So first, the mouse is anaesthetized, the head shaved, and the desired targeting position established. We insert a tail vein catheter and start the microbubble injection at the same time as starting the sonication, followed by injection of the model drug. We'll then perfuse the mouse and extract the brain and cryosection and image brain slices. So using a low pressure, so for example here at 0.2 megapascal, we get no model drug delivery. However, when we go above the threshold for drug delivery, so here I'm showing you 0.4 megapascal, we get delivery of a compound previously unable to cross the blood-brain barrier throughout the focal volume, as you can see here. The delivery is homogeneous, which is, I said earlier, is important for the treatment of DMG and a key feature of rapid short therapeutic pulses. So here we successfully delivered dextran to the pons region without any issues with the skull base or skull thickness. We also saw no tissue damage by H&E staining, as you can see here. Again, as I mentioned before, this is really important when treating DMG, as we want to be careful of long-term neurological deficits to a child's developing brain. We then proceeded to investigate if short pulses of ultrasound can improve drug delivery in a DMG tumour model. We used a murine cell line implanted in the pons region of C57 mice, and tumour growth was monitored by MRI, which you can see in the image on the left. We used the same exposure conditions and protocol as the non-tumour bearing mice, except we let the mice recover for the procedure for 90 minutes. The procedure was well tolerated, and the drug can be seen throughout the tumour region, shown in the image on the right. And if we zoom in here, we can see typical dextran objects throughout the tumour core. We indicated in the Z stacked video on the right. This is really promising for drug delivery as it suggests we could get drug distribution throughout the tumour. So now we know we can get delivery of a model drug to the tumour, we've started to investigate drug delivery. We chose LBH589 or panobinostat as it has shown promise in vitro, but therapeutic doses have been toxic in vivo. So we hope that by using short pulses of ultrasound, we can increase the concentration of panobinostat in the brain at a tolerated dose to avoid systemic toxicity. To do this, we first confirmed the in vitro toxicity in the cell line used for the tumour model, which you can see on the graph on the right, with a GI50 of 15.56. We first assessed delivery of panobinostat in non-tumour bearing mice. I found that at 4 hours after treatment, the concentration of panobinostat was higher in mice who received short pulse ultrasound versus those who received the drug alone, which you can see in the graph on the right. We see here that the concentration of panobinostat is higher in the back of the brain versus the front, indicating that the drug remains in the targeted region. So once the feasibility and tolerability of the procedure was established, we started to assess drug delivery in the DMG tumour model. We followed the same procedure as the non-tumour bearing mice, with 4 mice receiving drug alone and 7 receiving drug and ultrasound. Here, brain tissue was collected at 2 hours after treatment. We saw observable Evans blue delivery throughout the tumour, shown in the images on the right, and this is the case for all tumour mice receiving drug and ultrasound. However, when we quantified the drug concentration, while some tumour samples had higher drug concentration when treated with drug and ultrasound, overall there was no difference between drug only and drug and ultrasound. We know that blood-brain barrier opening was achieved in the targeted region due to the observation of the Evans blue. Panobinostat is a lot smaller than Evans blue, so it might be that the drug had entered the brain and then kicked out within 2 hours. We've only investigated one time point, and as I said, this is very initial work. In non-tumour bearing mice, the highest concentration of panobinostat was at 4 hours. So further investigation of different time points might give us an idea of the pharmacodynamics of the drug after FUS treatment. So to conclude, firstly, I've shown that rapid short pulses of ultrasound can deliver a model drug to the pons in non-tumour bearing mice and in the DMG tumour mouse model, with dextran uptake seen throughout the tumour and in the focal region. Preliminary work has also shown that short pulse ultrasound can increase the concentration of panobinostat in the brains of non-tumour bearing mice. And we're working to develop and assess panobinostat delivery in the DMG tumour model, with the overall aim to develop the drug delivery system and expand treatment options for DMG. Lastly, I'd just like to thank everyone involved for their ongoing support and help for this project, as well as my funding bodies.